Hello everyone and welcome to Your Health, Your Choice. I am Dr. Roopnarine and we're coming to you live from our studios at Tulare Heights in San Fernando. This is Your Health, Your Choice and today is Wednesday, the 31st of May 2022. On tonight's program, we'll be discussing common emergencies. With me in studio tonight is Dr. Jonathan Sookbir. Dr. Sookbir is an emergency medicine physician. Dr. Sookbir is also a qualified basic life support and advanced cardiac life support instructor. As usual tonight, guys, our numbers should come up at the bottom of your screens and we'll do our very best to answer each and every one of your questions during the program. So guys, tonight we're going to talk about emergency medicine and please feel free to send in your questions as you go along and we'll do our very best to answer them. So let's say hello and welcome to Dr. Jonathan Sookbir. Jonathan, welcome to the program. Welcome to Your Health, Your Choice. It's a pleasure to have you.
It's a pleasure to be here.
Jonathan, it's a really important, relevant topic, emergency medicine. It's something that we need to get information out to the public about. People that have their questions, what to do is basically the question that people will come at us with. Let's start with something really relevant, right, Jonathan? Today is a really rainy day, people flying up and down the highway. What would you suggest? I mean, if one of our viewers driving on the highway, if I'm driving on the highway tonight and suddenly we come across a car accident, a car on the road, which has happened to me before, you see a car on the road, a passenger inside the vehicle, the driver inside the vehicle, no one else around, you're the first person to the scene. How would you advise our audience at home to proceed? What do they do?
Right, so good evening, everyone. So in a situation like this, right,
yes,
it is always important that I always say the first and most important thing in any emergency medicine approach to any situation is safety.
Correct.
So safety of yourself, so make sure that you are clearly off the road, you're on the emergency shoulder, you're parked, you put on your hazard lights, you exit your vehicle, you lock your vehicle because that's still an unsafe environment if you want to help, and that's emergency of yourself and your property, and emergency of and safety of the environment in which you're going to operate in. So make sure that if you see an accident, if it's safe enough for you to approach the situation, there are no fires, there are no fuel leaking out that could put your life, because if you're the first responder and something happens to you, who's going to respond to your emergency?
Right.
So it's important that
put on your mask first before you
correct,
to help
you know,
others.
before you jump into a burning building, make sure you secure yourself first.
Right.
So after you ensure that yourself is safe and the environment in which you're working is safe, the next thing you do is try to assess the situation. Right? The type of accident, how many persons in the vehicle is involved, did the airbags come out, right? What is the orientation? Are the persons seriously injured in the vehicle? And if they are injured, what are the things that you can actually do? So you assess
as a member of the public.
As a member of the public.
An untrained healthcare professional.
You ask them if they are okay. That's a good place to start. If you're not getting any response for them, you make sure that you call all of the emergency numbers: police, fire, ambulance.
Okay.
All three are important in assessing and firstly eradicating the patients, extraditing the patients out of the vehicle. That's important. That's all three of them function as primary first responders in our community. They are the most trained first responders, right, in our community, but we depend on the public as pre-alert systems as well. So assessing the situation, calling for help is the most important thing, right, and try not to move patients out of the vehicle, because if they have spinal injuries, by moving them it can make it worse and it can lead to further injuries, right?
Is that the limit of what an untrained professional should do?
In a safe, ideal environment, yes. Right? But there is always this inclination of our adrenaline to do more, right? And if you think that you are capable of doing it in a safe way, if you can assist to help. If you see bleeding, you can put some pressure on the bleeding, but you try not to make those patients and persons move too much, because spinal injury is a very, very real injury, and it's a very common injury in all motor vehicle accidents.
Definitely. I mean, the thing that we commonly see is observers pulling people from vehicles and moving them.
Yes.
And that could cause more long-lasting injuries to the person.
And we have a little saying in emergency medicine: C3, 4, and 5 keeps the diaphragm alive. So that's basically your neck bones, right? So if you have any damage to the spinal cord region in the neck, C3, 4, and 5 keeps the diaphragm alive, and the diaphragm is responsible for breathing appropriately.
So basically you could cause more damage.
You could cut out your breathing centers, essentially.
Right. What about someone who is trained in first aid and basic life support? Can they add more to that situation?
They can add more. As I said, part of their responsibility in a situation like that is to safely extricate them out of the vehicle in a safe manner, holding the C-spine manually, getting them from a sitting to a lying position. There are different techniques that trained first responders can use to do that.
All right.
Right? But in situations where the car might be really badly banged up, you may need assistance from the police and the fire with jaws of life to take them out of the vehicle, etc.
So what I get from you there is make sure the environment is safe.
Correct.
Check on the person and call for help.
That is the most important.
What happens next to that person beyond the first observer there, the first responder there? The call is made, police arrive, ambulance arrive. Let's describe what happens next to an accident victim.
So the ambulance and the police comes.
Yeah.
The patients or persons, they check on them, they assess them.
Yeah.
Right? They assess their airway, which is very important. It's airway is to make sure that they can speak clearly. There is nothing obstructing the mouth from air going from the nose and mouth into the throat and down into the lungs. Make sure they have no chest injuries. Their breathing is important. They'll check to see if their windpipe is in the center. They'll check to see if they have good breathing sounds, good heart sounds.
Right.
One of the first things that they actually check is pulse to make sure the patient is alive and conscious level. So they'll ask, hey, can you hear me? Do you know where you are? Do you know what happened? Right. So those are some common questions that a first responder, lay first responder, can ask the patient.
As well.
Because when they call the ambulance, they'll want to know those information. Yeah.
All right. So the police arrive and the ambulance arrives. So then they begin to remove the person from the vehicle.
So they move them in a very coordinated way.
When you say coordinated, what do you mean?
So the first thing is that they'll ask the same questions like the lay first responder. They'll assess their pulse, and if they are oriented and they are speaking to them, they'll extricate them out of the vehicle. So someone will hold the C-spine or the neck, right, and they'll take them out of the vehicle gently, put them on a backboard, strap them in. That is to protect the axial spine from the neck all the way down to the bottom, essentially.
I've responded to emergencies as well, and one of the common things you get is people saying, I'm not going to no backboard. I'm not going to no spinal board.
It's an uncomfortable thing.
It's an uncomfortable thing. Yet it is extremely important. You need a trained professional to make sure that person doesn't have a back injury, and until then, you have to be on a backboard.
Correct.
So when this person reaches to the hospital, they meet a man like you.
Right.
What do you do then?
So our first goal in the hospital is to get some vital signs for the patient. And quickly, the patient is met in a system in the emergency department called a triage system, where any motor vehicle accident is considered an emergency. So that patient must be assessed within 15 to 30 minutes or less than that.
Right. Ideally.
And they assessed by an emergency physician who will check their airway, breathing, circulation, deformity, exposure. We expose the entire patient, and that uncomfortable thing off the backboard, we can remove the patient safely from the backboard at that time. If there are spinal injuries, there are other mechanisms. We don't usually keep patients on the backboard unless we suspect a very frank spinal injury. Right? We basically, now with the access of ultrasound in the department, we do a quick scan of their chest, their belly, make sure that there's no internal hemorrhaging from the patient. And once the patient is comfortable, if there's in pain, we treat them for the pain, of course. We get them to some investigations like doing basic x-rays or CT scan if needed. And then we gauge their injuries from there. And treat those
from there. All right. That's fine. So how many car accidents would we normally see I'm not going to call the name of the institution you work, but it's a big institution. How many car accidents do you normally see in an emergency room department in Trinidad and Tobago?
On a shift or on a daily basis?
On a daily basis.
On a daily basis, we can see up to, so it varies.
Of course, yes.
And I would say that it will be at its peak over the weekend.
Yeah.
Because that's some of the common things that promote higher incidence over the weekend is drunk and drinking and driving.
Yes.
Right? Reckless driving, coming from parties late in the night, sleeping behind the wheels, working late hours, working late shifts over the weekend, falling asleep behind the wheels.
Yeah.
Wet roads is a big thing as well. Over the weekends, we see the majority of accidents.
Yeah.
Right? And on a weekend, our average over a weekend might be somewhere between 15 to 20 patients, right?
On a day?
Well, on a day, it may be between 7 to 8.
Right. So okay, on a weekend, about 20, sorry.
Yeah, 20 for the most, right?
Right.
And the major ones, so like those who would need like ICU admissions and emergency surgery, might be 3 out of that 20 for the most, right?
Another common thing that we'll probably be seeing, or that you're probably seeing nowadays, is gunshot injuries, right? What would you suggest to an average layman on the street if somebody next to him is shot, right? So this is a man, he's been shot, he's lying on the ground, and a guy, one of our audience members said, let's come upon him. What are they to do?
Right. So that's another important question, and it comes down to the same rule that we started off with. Safety is important first.
Right.
If someone gets shot, you have to make sure that you are safe and the environment that you're in is also safe.
Of course.
So you have to make sure that when a patient is shot, you don't just run straight right into helping that patient.
Because you could be the next one.
You have to make sure that that area is cordoned off and clear, because somebody might come back to finish the job for that patient if it isn't finished already. But safety of yourself and safety in the environment. Once you are happy and comfortable, but before you actually are happy and comfortable to approach that patient, call for help. Police is one of the first persons they call.
And they will
ambulance,
from there.
Ambulances. You don't necessarily need fire in a situation like that, unless the person is in an area where they cannot be removed easily.
Correct.
Right? So what you'll need is really the police and ambulance in a situation like that. And once you are happy that the area is cleared off, you can to assist the patient, you can go, sir, can you hear me? Are you okay? Right? Feel for their pulse, speak to them, get an awareness of their mental status.
I mean, they'll be screaming and bawling, and they'll have a massive bleed on the leg, for example. What does it first respond to? Time,
well, basically by asking those questions, you know that their airway is good, because they will quicker die from an airway problem than bleeding from a wound, right?
Good point.
But if it's a major wound, you want to put some pressure on that wound.
Right.
Find where that wound is, and they may have multiple, because a gunshot usually leaves 2 wounds, right?
Right.
So you usually find where that wound is, and you put pressure on that wound to stop the bleeding.
Right. And there'll be two wounds.
Right.
An entry wound and an exit wound.
In some instances, they may just only be an entry wound.
Right.
Depending on the orientation of the shot.
Right.
And you put pressure on any bleeding wound. If it's a wound in the limb, right, and you can put a tourniquet on it. You can ask Josh to pull up the slide on stop the bleed, and you can see.
Josh, you can put up a slide on stop the bleed if you have that there. Continue on until
so basically, if it's an injury to the limb, you can use tourniquets. Tie above the wound, at least 2 to 3 inches above the wound. Tie tightly, right, and it may pain and ache a lot.
There you go, there, Doc.
Right? That will actually help to stop the bleed. You apply pressure where there is bleeding, at the site of bleeding, and if it's a large wound, you pack it with gauze into the wound and apply pressure as well, covering the entire wound. And of course, the emergency number is there as well.
Right.
It is not only one approach, you use all 3 approaches.
And you could use anything for a tourniquet if you don't have a proper tourniquet.
You can use simple things as you take out your jersey and you can tie. Most of these jerseys have a stretching stretching properties with it. So you can use your jersey, tie 2 to 3 inches above the wound until it hurts the patient. So you know that you're compressing a nerve. And if nerves usually run close to arteries, so you know you're compressing the vessel.
And I think nowadays they have really great first aid tourniquets available.
Right. Correct.
And I think tourniquets are extremely important.
Right. And they're not expensive at all. And another important thing about
do all our first responders carry tourniquets? Well, they should anyway.
All GMRT ambulances ought to be equipped with tourniquets.
I suggest maybe the police department should carry tourniquets.
I have not seen much from them, but fire does usually have tourniquets
as well.
And you don't tie a tourniquet over a joint, because it doesn't work, because it just wounds across the joint. Right.
So you tie it above the wound?
Above the wound, but not across a joint.
Okay. Doesn't matter how far above or anything like that?
2 to 3 inches above.
2 to 3
no more than that.
And How long do you leave the tourniquet on
So you
for?
leave that tourniquet until help arrives, so the patient gets to the hospital.
Right.
And you usually put a time at which you apply that tourniquet, because that is important, because when doctors see the patient, they want to know how long blood supply is pretty much restricted to the limb.
Okay.
Right, so time is important.
Yeah.
And location, and you leave it on until definitive help
All right.
reaches.
So if you're a man in the community, somebody gets shot next to you, you make sure you're safe, call for help, call the police.
Of course, yeah.
And if you're absolutely sure that nothing is going to happen, you go out there, you assess the man, you say, hello, what's up, make sure his breathing is clear. You apply extreme amounts of, you extract a lot of pressure to the wound to stop it from bleeding.
Correct.
And you get a makeshift tourniquet and you apply that above the wound.
Once it's in the limb.
And if somebody in the community does that, they have done a great service to that
Great
victim.
service to that person, yes.
They would have probably
correct.
saved his life.
Yes, because it takes about 3 to 5 minutes for somebody to completely bleed out
From a wound in the
from a
leg.
wound, from a major
Arterial
artery or blood vessel wound to the leg.
All right. So the next thing is obviously that we see. I mean, it's a pretty intense show tonight, right?
It's intense, yeah. Emergency medicine is intense.
Some graphic situations.
Yeah.
But it's important to have the knowledge.
Of course.
What do you do if someone gets stabbed in front of you and you see them with that knife inside his stomach?
Right. So the same situation applies. We come back. The first and most important thing is safety. Right. Safety of yourself, safety in the environment that you work in. And once that you're happy and you're called for help, because your backup mechanism is because that you as a first responder cannot treat this wound entirely on its own. You always call for help before you approach the situation. You
Call for help from emergency services and from somebody else around you as well.
Correct, right? And you do not, any impaled object or object that is in any part of the body, you do not attempt to remove, because that serves as something to stop the bleeding around.
Right.
So you pack gauze around, or you pack a cloth around the object over the wound.
I'm really glad you said that, because the natural instinct of somebody coming is to pull out that knife.
Yeah, because that's causing pain, right?
That's causing pain. Or the man might pull it out himself.
Oh, right. So you encourage the patient not
Nobody
to pull it
touch that knife.
Yeah,
Or nobody
whether it
touch
be a knife,
or whatever it is that impaled the man.
Correct. A bottle, a knife, an object.
Why is that?
Because
if you pull it out,
that object could serve. That's where a hematoma or a blood clot forms around.
Right.
It's the center of it, right? And it will actually help to stop the bleeding. Removing it will actually cause the bleeding to just gush out, and that could be catastrophic for the patient.
And I think that's probably the most important thing for the first responder to know.
Correct. Yes.
So I just want to tone it down a little bit.
All right. I don't think emergency medicine ever gets toned down.
It never gets toned down. But I just want to bring it to something you might see. A lot of kids end up in the emergency room as well, right?
Yes.
I think you see a lot of kids. So something very common, a family might be at home there with a little toddler, and toddler having fevers. A lot of the time you see these kids come into the emergency room as well. You know, the parents bring them and listen, the kid has really high fever, it's 2 o'clock in the morning, help me.
Right.
And you're there to help. Now, what advice would you give parents at home when a kid has a fever, and to help break the fever or whatever? And when should the parents say, hey, time to come to the emergency room?
Right.
You know what I mean? When should they say, this is enough, that we're going down to the hospital, we need to see the doctor?
Right.
When is that decision made?
Right. So first let's understand what a fever is.
Yes.
Because feeling hot is not necessarily a fever.
Yeah.
Right? So a fever is defined as anything that is above 37.5 degrees.
Yeah.
And you must have a temperature thermometer at home to check that fever.
Yeah.
So that's one of the important things. But even if you can't afford a thermometer as a parent, as a family, relative, and you feel that the patient has a fever and they're burning up literally in front of you, right? One of the first things that you do is try to get them to minimal bare clothing, right? You sponge them off with room temperature water, not ice water, not alcoholado, not mentholated spirit, or all of these things, right? Because you want the temperature to drop slowly. If it drops too fast, it comes back like a thermostat regulating a room.
And that's a little bit of a change from the thinking in the past,
Correct,
right? Because when I used to work in the ER, 20 years now, we used to nurses, I mean, as soon as the baby comes in, the nurse takes the baby from the adult, go, oh my gosh, this is a fever, and dunk them into cold water.
Correct.
That was the teaching. A lot of the patients will still think that's the teaching. Right. But you are saying it's changed.
Yeah, so clinical and evidence-based medicine is pointing in this direction.
Yeah, so it's not cold water anymore.
It's tepid sponging, we call it, right?
Tepid
sponging, right?
Tipping is what?
Like taking tap water, room temperature water, soaking it in a cloth, and just just tapping all over the patient, leaving little drops all over, and putting that patient under a fan or fanning them. So as the water evaporates off of the patient, it removes the heat internally from the patient.
Bathing the kids?
Bathing the kids, but in room temperature water as well, not cold water, not ice water.
In Caribbean countries, you use a lot of Limacol. What do you think about that?
Limacol has its
alcohol based.
Yeah, it could, for the younger babies, especially the toddlers and stuff, it could drop because their body surface area is so small. It can drop their temperature too quickly, right? And it can cause a rebound higher fever. Right? So that's something that you have to be cautious with, especially the younger children. Adults, they could use it as to their heart's content, and it doesn't really bother them too much. But the little kids, it's important.
I think the big point to get across to the audience is that you're saying for the toddlers, the young children, we want to bring down the temperature, but we want to bring it down nice and slowly. We don't want it to shoot all the way down.
Correct. That is correct. Yes.
Why we don't want it to go all the way down?
Because when it goes all the way down, they end up with hypothermia, a rebound hypothermia. And so their brain's hypothalamus, which is your internal thermostat, regulates up the temperature and fever even higher. Because fever and heat is a way of killing any internal pathogens. So in the brain's mind, I'm not doing a good enough job. So let me just vamp up the temperature a little more higher.
All right.
And that's the problem.
We have to take a little break. And when we come back, we'll continue on about that fever and the kids and when should the parents go to the hospital.
No problem.
All right. So, guys, we're here with Dr. Jonathan Sookbir. He's an emergency room physician. And he's giving us some advice on common emergencies. Feel free to send in your questions if you wanted any clarity on anything. It's a very important program. And we'll be back in one moment.
Looking forward to hearing a lot of testimonies from Married to an Angel. I know that my parents have an excellent program. Right after we got married, we were doing the classes and stuff with them, and I learned a lot. And I'm looking forward to couples, especially who weren't a part of the program before. I'm looking forward to seeing these couples learn a lot from the program. A lot of we have learned, to make their marriages better.
International Marriage Tune-Up 2023, June 17th to the 19th at the Hilton Hotel and online. Give us a call at 868-304-4145 or check out our website at marriedtoanangel.com. You can find us on Facebook and Instagram at Married to an Angel. Register today. It'll be an investment you wouldn't regret. And remember, it's not about finding the right mate, but being the right mate.
Hi everyone, I'm Stacy from Stacy's Kitchen. Check out our new episodes, Season 3 of Stacy's Kitchen at our new time, 5:30 p.m. on Mondays and Wednesdays, right here on ActnThe Voice. I will be whipping you up some flavorful and appetizing dishes. As they say, good food makes a good mood. So guys, stay tuned for this culinary explosion right here on Stacy's Kitchen.
Connect with ActnThe Voice on Facebook or Instagram at ActnThe Voice.
ActnThe Voice, your family-friendly station.
All right, guys, welcome back. Your Health, Your Choice. I'm Dr. Roopnarine, and I'm here with Dr. Jonathan Sookbir. We're talking about emergencies. At this time, I'd like to formally invite you again. Send in your questions, send in your comments, and Dr. Sookbir will answer it. Doctor, we were talking about the kids, the toddlers with a fever, and we had reached sponging them off.
Right.
Tepid water, which is normal temperature water, not cold,
not hot,
hot water. continue on from there, what else should the parents do to try and bring down that fever?
Right. So along with doing that, it's always advisable that you give a dose of Panadol appropriate to the weight of the child. A lot of parents come to us and say, well, Doc, I've been giving Panadol, but it's not working. And one of the reasons that it's not working is that, Doc, I've been following the instructions behind the box. But that's usually for a special population. Like, so it's usually, Panadol is usually measured per weight per dose according to the Caucasian or the American population. And it's usually given at 15 milligrams per kilogram after the age of 2. And under the age of 2, 10 milligrams per kilogram.
Right.
So a lot of parents come underdosing the child.
Well, they might have underestimated the weight.
Underestimated the weight as well.
Yeah.
So it's important to know your child's weight as they're growing up. Always have a little bathroom scale at home.
Right.
Always have a little thermometer. Those are real important things.
Right.
Just like how an adult would have a pressure and a sugar machine.
Right.
And always constantly measure. You know, you have your growth charts here, you have your weight charts and stuff.
Right.
And you give the child the dose according to their weight.
Okay.
So some concerning things about fever. When should I proceed to the emergency?
Yeah, when should the parents say, listen, this is enough.
Right.
I'm not taking a chance. I'm coming into the... I mean, they could do it at any point in time. Once a mother, we have a golden rule. Once a mother bring baby.
I worry too.
Right, yeah, because once granny worried.
Yeah. So
once granny worried, we worried.
So if the fever is very high, like above 38.5 or anytime like 39 and above, right, I would urge parents, take them to the emergency department. We are looking at a dangerous source of infection, a bacterial source of infection that might need antibiotics, right, or some source that might need looking into. If a patient or a child is having a seizure because of a high fever,
which happens
commonly in the toddler age, right?
Febrile
convulsions, we call them, right? You bring them straight to the hospital. You try to drop the temperature by tepid sponge in them. You give them a dose of Panadol. If you have a video, everybody have a video camera now, take a video of the seizure and come to the hospital, right, as soon as possible, because once that fever starts to pick back up, they can get recurrent febrile seizures, right? So those are some important things that you do. Vomiting, diarrhea, not tolerating, and decreased activity of the child is also concerning enough symptoms to bring them to the hospital.
Okay. I suppose diarrhea and vomiting children can get very dehydrated very quickly.
Dehydrated, and that's one of the reasons that they might need some help from the emergency doctors.
Something not spoken about much in terms of public education, right, with kids, and I want you to just explain it, because it's something we do often see. Well, I probably you might have seen it obviously more often than I. What is meningitis? So
meningitis, the definition of it is inflammation of the tissues overlying the brain, right? So you have tissues overlying the brains, or coverings of the brains, called meninges. There are 3 different types of layers, and when there is inflammation of it, whether it's caused by a virus, a bacteria, or some sort of inflammatory response, hyperinflammatory response to any sort of infection, you can get inflammation of the meninges and you can have meningitis. Meningitis usually presents as a patient with high fevers, seizures, right? Acute confusion, disorientation, very drowsy, not their usual self, neck stiffness. When they look in the light, they get severe headaches. When they hear loud sounds, it's annoying. They're very irritable and cranky, right? Those type of symptoms, essentially.
What age group does it normally affect? Any age group, obviously.
Meningitis affects adults as well, right? But it can affect children because of the preponderance to develop upper respiratory tract infections. So it's more commonly and more importantly in children is that they're not fully vaccinated or immunized. A lot of the meningitis presentations are bugs that are within that vaccine schedule. And thankfully our country covers this wide range of vaccination program where it covers the pneumococcal vaccine, which was one of the major culprits in meningitis in the past.
A lot of the times meningitis could present with a rash as well.
It starts off as a rash, yeah.
Starts off with a rash.
So yeah, and it could could be a manifestation of meningitis.
The point I'm trying to bring across to anybody that may be listening out there is if a child has fevers and you see a rash, you go straight to the hospital. Is that a reasonable request?
I think that's a reasonable
because
request.
Because doctors like me might be worried about meningitis.
Yeah, it's better to see that a doctor says that, hey, this is just something not to worry about.
We don't want to see rashes in kids with fevers. We want the doctor to see those. We want the emergency room guys or the pediatrician to see those. Don't sit at home with those.
Correct. Yeah.
Another thing that you commonly see, both in general practice, but I suppose you see a lot of it in the hospitals, and we always get phone calls about it from people calling into the clinic. Dog bites.
Dog bites.
Doctor, I was walking, taking an evening walk, and the neighbor, the wicked neighbor, like dog, or the damn dog next door, ran away and bit me on my foot. That was a day ago. What should I do?
Right.
What should the patient do when they're bitten by a dog? And what does the doctor do when a patient is bitten by the dog?
Very good. So that's a very good question. We have a slide with bites on it. If we could pull it up so the public can see as well.
Yeah, go
so
ahead.
bites is a very important thing, and you could dog bites specifically.
Yeah, let's go through the dog bites first.
It's a very, very nasty wound. Right? Very, very, very nasty wound. One of the important things that you want to do with the dog bites is look at the location and the extent of the wound. Is the wound just bites and puncture wounds, or is it a laceration where it's an extensive injury where tissues are gaping out? Right? In that particular situation, you'll definitely, all bites must proceed to the emergency room.
All bites?
All bites.
Okay.
Right? We're very stringent about that. All bites to the emergency room.
Okay.
Because one, we need to know the patient's tetanus update.
Right.
They would need to get their tetanus updated at that time if it haven't yet been updated.
All right, you can take it down there, Josh.
Right. These type of wounds at home, the first thing you do is wash. You don't have to get saline to wash it. Just simple tap water. And even the clinical evidence-based medicine is suggesting tap water is as effective as washing it off with saline.
Yes.
Right. So you wash that wound, wash it until the tissues turn pink.
Yes.
Right. Put a dressing over it and proceed to the emergency room.
Right.
Right.
So you're basically saying that all bites straight to the ER.
Yeah, whether it be cats, monkeys, dogs, animals, humans as well.
Right.
Proceed to the emergency. That is a dirty wound.
Right.
You'll need to update your tetanus if not updated, and you'll need some antibiotics and a proper antibiotic dressing and assessment of the wound by an emergency physician.
All right. Is it still combination antibiotics that you'll give for bites, or is it single antibiotics?
It's usually single antibiotics.
Oral or
oral antibiotics,
okay,
depending on the severity of the wound, the location of the wound,
right,
and if the patient is immunocompromised in the sense that elderly, diabetics patients on steroids, patients who have diseases such as rheumatoid arthritis, lupus, whose immune system is compromised, we usually take extra precaution, keep them in hospital, and give them a course of IV antibiotics for about 48 hours.
That's the dog bite. Same with human bites?
Same with human bites as well.
Same protocol?
Same protocol.
Right.
Some of the bugs are a bit different, but the general protocol remains the same.
Right, and I suppose once that patient goes home from the casualty, even if they notice any redness or whatever, they come straight back
back, and we usually give them follow-up within 5 to 7 days for wound checks. So we ensure that it's healing properly.
All right, you mentioned tetanus vaccination. How long after bite? I mean, somebody should have tetanus vaccination regardless of the status, right?
Everyone.
Someone gets bitten with a dog. It's extremely important that they come in right away to get a tetanus.
Right. Yeah.
Tell us a little bit about tetanus vaccination regulation. How often should someone have a tetanus vaccination? When would somebody need to have a booster shot? In terms of injuries, tell us a little bit about that.
So tetanus, you would usually get your tetanus updated when most kids write their SEA exams.
Yes.
Right? And usually 10 years after that, the immunity of the tetanus weans down. So we usually encourage boosters 10 to 15 years after, right? But if you get a wound, whether it be a laceration, a cut, a puncture wound, any sort of wound, right? And you're after the 10 years of getting your tetanus vaccine, you get another one.
Right.
If you have never gotten a tetanus since SEA exam,
yes,
and you have crossed the age of 50, going into 60 in that decade of life, it's always advisable that you get one.
Right.
If you didn't get one.
All right. So if someone has tetanus coverage, right? Let's say they got it 10 years ago. Actually, real specific stuff now, and they got bitten, let's say yesterday. Do they need to get another?
I will give them it. Yes.
You'll give them it just because of the risk.
Yes. And if they're not sure about their tetanus status, we give them it still.
Right.
It's better that we do than we don't.
Have you ever seen a tetanus infection before?
I have seen only one, and that was when I was a medical student in my final year in Jamaica.
Yeah, and it's pretty graphic.
Gross.
Yeah, it's pretty graphic, so we try to avoid that.
Those patients are in isolation or hazmat suits.
What about the famous scorpion sting?
Right, scorpion stings.
Right. What about that? Should those patients stay home or should they come to the hospital right away?
Right. So first, let's first assess what type of scorpion, and is this a scorpion that really stung me?
All right.
That's one of the first things that we have.
So you suggest to them that they bring in the scorpion?
If they can.
Right.
Honestly, if they can, or if they could take a picture of it, because now with our videography, it's easy to do it. We always have our phones in our hands.
And then we also have, with pictures, we also have access to our colleagues all over the world, all over the country to consult with.
Right? So we actually have a picture on a slide of some of the poisonous scorpions in our country.
Okay,
right?
you can pull that up there, Josh.
Pull it up and see. So it's under bites and stings. So what actually happens is that these two types of scorpions, very, very dangerous. And there's actually a time frame before which you need to get to hospital. And some concerning symptoms associated with these type of stings.
Okay,
right?
You could go ahead and elaborate on that.
It might be, right, so those two type of scorpions, right, Trinitario and Titius, right, those pictures there of these two scorpions above and below, right, those are the concerning ones, right, those are the ones that are poisonous in our country at present.
Right.
There are over 100 species of scorpion that is poisonous, because these are the two that are endemic to our country and that can cause injuries. Things like concerning symptoms after scorpion bites are excessive sweating, palpitations, short breath, vomiting, abdominal pain. Those are signs and symptoms of the toxins taking its effect, causing an autonomic dysfunction. And we really need to get to hospital immediately because we actually have an antidote to combat that particular effect.
Okay.
Right?
So that is the symptoms of the toxin in the body, right?
Right.
So somebody who's being bitten by a scorpion should still proceed immediately to the hospital with the scorpion if they can.
Yes.
And is it that you give them the antivenom one time?
So it depends on their symptoms when they present to us.
Okay.
Because one of the basic concepts of scorpions or any sort of animal bites is that the majority of bites and stings are dry bites and stings.
Yeah.
So we first assess the patient properly.
Yeah.
Are they having symptoms indicative of an antivenom, right? And if they're not, we don't give them.
Okay.
And if they are having those symptoms, even if it is a subjective symptom, we give them the benefit of the doubt by giving it to them.
Are those patients admitted to hospital?
They are admitted to hospital for at least 2 to 3 days observation.
And why does the doctor admit them? What happens then other than observation?
One of the major things about scorpion toxins is that it causes something called pancreatitis. And that is one thing that we need to check on the blood. We do blood investigations for the patient, and we check to see if certain enzymes in their body are rising over that period of time. So that's a dangerous side effect of scorpion stings specifically.
And snake bites.
Snake bites. Now, snake bites is my pet peeve. I like this topic. I studied it a lot.
Okay.
And there are 4 dangerous snakes in our country, contrary to popular belief.
You have a slide on it?
We have a picture of it.
Oh, that's
pull it up.
so
and we have a nice little poem if you want to put it.
You go ahead, doctor.
So the two top snakes are the coral snakes, right? And the 2 bottom snakes are the mapapee, right?
Okay.
Now these snakes are not usually found in our urban countries. So you don't find them in San Fernando. You don't find them in Gasparillo or Marabella, right? You find them more in places like Moruga, Tableland, Cedrus, right?
Yeah.
More in the forested, bush-infested areas. So hikers, hunters, these are the persons who live in rural communities, right? They are the ones who are more exposed to it. And So we have a little mnemonic. When you see that coral snake with the red and yellow, that kills a fellow. So that you can actually remember that,
it like that.
right? So
red and yellow kills a fellow.
black and white, you're all right. That's
Black
not so much. It is not. But when you hear the red and yellow, you get to that hospital. You take a picture of that snake, get to the hospital.
Okay.
We have anti-venoms in the hospital for these snakes specifically.
Okay.
Right? In any district health facility.
Yes.
Right? In under Southwest Regional Health Authority, we have all of the anti-venoms for it. In any hospital and district health facility in our country, we have the anti-venoms for this. Right? And even for the Mapapee as well.
Right.
The Mapapee comes from the Amerindian name vipers. So they are basically viper snakes. Right? And they have dangerous toxins that can both cause neurological effects and hematological effects as well. So they can cause bleeding and they can cause clot formation. So these patients need admittance to the hospital, monitoring in an ICU setting, anti-venom, and get the toxicologists involved early. We usually have a poison control center right in our country in Sandy Grande. We call them up and say, hey, look, we have a patient and we suspect that they're bitten by a certain type of snake. What are your advice? Are we going along these certain protocols? And our department have clear outlined protocols for snake bites, whether it be a Mapapee, whether it be a coral snake. So we're very well covered and versed in it, and we have all the necessary anti-venom to treat these type of injuries.
All right, I'm really glad that you showed the audience what the snakes look like as well. So Doc, we have to take a second break.
No problem.
All right. So guys, here we have Dr. Jonathan Sookbir. We're talking about emergencies. Send in your questions, send in your comments, and the doctor is here to answer it. We'll be back in one moment.
So you know, a lot of times when things going good, it doesn't feel like if you need a tune-up. That has happened a lot. And then when you get there and you're open to all of this information, you realize, wow, boy, I was slipping here, I was lacking there. You know, so we've had sessions before with Dr. Mendoza where we dealt with finances and how to manage money well and that kind of thing. So there's always room to learn more. There's always room for improvement. And honestly, that's what I'm looking forward for.
International Marriage Tune-Up 2023, June 17th to the 19th at the Hilton Hotel and online. Give us a call at 868-304-4145 or check out our website at marriedtoanangel.com. You can find us on Facebook and Instagram at Married to an Angel. Register today. It'll be an investment you wouldn't regret. And remember, it's not about finding the right mate, but being the right mate.
Sends a word, it serves a purpose. It serves a purpose because you serve a purpose. When you hear no, I want you to think next. So if God didn't let me do that, next. Jesus didn't call them to leave their boats. He called them to push out a little. It's a little decision so that I would rely on the grace of God. It's the blessing of both.
All right, guys, welcome back. We're here with Dr. Jonathan Sookbir. We're talking about medical emergencies and their management. Josh, I think we have a question. You can put it up. What are the signs of having a stroke, Doc?
So that's a good question, and I think we will actually comment to that topic.
Yes, we will.
So many signs of having a stroke, and it can range from simply starting off by numbness and tingling to the face, right, to speech disturbance where you're not able to articulate your words properly, where you have facial asymmetry where one side of the face looks flatter than the other, right, where you're having weakness to the upper and lower limb, persistent dizziness is also a sign of stroke.
Okay.
Acute confusion is a sign of a stroke.
Yeah.
And even seizures for the first time could be a sign of stroke. But it all is in the description of a patient having risk factors for a stroke, right? Now, that doesn't mean to say that patients outside of that category may not get a stroke, right? But they are the ones more likely to get a stroke. So patients with diabetes, hypertension, hypercholesterolemia, and patients generally over the age of 40 years with those symptoms, right, are at risk of getting a stroke.
Right.
In our society today, it's one of the commonest presentations. On a daily basis, patients admitted to the hospital, the majority of medically admitted patients are stroke patients, right? And those are some of the main signs and symptoms of a stroke.
Okay.
Yeah, simple things like that.
All right. What does the family do at home when somebody's having?
So from the time the symptoms begin, you don't delay. You get to the hospital as soon as possible. Time equals preservations of brain cells. So we get to that hospital as soon as possible, right? Some relatives and some family give aspirin to chew. We do usually advise that it is be done because sometimes there are two main types of strokes. There's a bleeding one and there's a clot formation one. If it's a bleeding stroke and you give aspirin, it can perpetuate the bleeding, propagate the bleeding.
And a professional should really assess it.
Yeah, so we don't really advise on giving aspirin and taking to hospital for symptoms of a stroke. We advise on getting them to hospital as soon as possible.
What happens? What happens in the hospital to that patient?
What happens in the hospital?
What do you do?
So as soon as they arrive in the hospital, they are deemed as an urgent patient to be seen within 2 hours, right? And those patients get an ECG, they get blood tests, we check their sugar levels because low sugars is a great mimicker of a stroke.
Okay.
We check their electrolyte levels, their sodium, potassium, their kidney function tests, also great mimickers of a stroke, their calcium levels. And we do something called a CT scan of the brain. The CT scan gives you good tissue definition of if there is damage to brain tissue cells, right? And it can actually tell you whether or not this patient is having a stroke, which side of the body, and what is the extent of the stroke, if it is an evolving stroke, if it is a complete stroke. And sometimes a patient may be having symptoms of a stroke and we do a CT scan and it doesn't even show up on the CT scan because it may be too early. So they may benefit from what we call an evolutionary scan, where we repeat it within 24 to 48 hours to see if the symptoms are in keeping with something that is showing up in the brain.
Okay, that's a very good answer there, Doc. Very, very important, and I don't think we could leave the show without talking about it to follow on. Somebody at home watching the show, we've gone through the scenario, different guests as well, but it's so important. Daddy or mommy just suddenly grabs their chest pain, and they go, I think I'm having a heart attack.
Right.
What does the family do?
Right. So one of the most commonest presentations in the emergency department is chest pain, if not the most commonest emergency.
Right.
Chest pains is it's amazing. It can range from simple muscle injury to as bad as a heart attack, to as bad as a tear in blood vessels or clot in the lung, all of which are dangerous.
Yes.
Any chest pain, take very seriously, proceed to the emergency department.
Okay.
But the characteristics of a chest pain in keeping with a heart attack is it's so unique that you can't miss it. A chest pain that is described as pressing in nature, like someone sitting on your chest, right? Someone squeezing your chest, that is indicative of a heart attack.
Yes.
If that chest pain is radiating or moving to the shoulder, the back, the jaw, or moving all the way up from the center of the chest to the throat, indicative of a heart attack. Chest pain associated with cold sweating, where the patient is sweating and it's making cold at the same time.
Yes.
Nausea and vomiting, heart racing off, patient is short of breath.
Yes.
Those chest pains are indicative of a heart attack. And they are usually accentuated by work or exertional activity. So a patient may be cleaning the roof. I had a patient just Sunday ago, and he was doing some chores, never had a heart attack or any chest pain before. And he was just cleaning the roof, doing his usual chores, and that exertional activity gave him a heart attack, right? So his chest pain was accentuated by work, and usually chest pain accentuated by work is what is in keeping with A heart attack, exertional type of chest pain.
Right. So you described it, but what does the first responder, the person there sitting with the patient, do?
This is where you can give the aspirin. Right? So you give your patient at least 4 aspirin to chew. You take them to the hospital. You keep them as upright as possible. Right? And you take them to the hospital. You can give them to drink some water with the aspirin now, and you take them to hospital immediately so that they can get an electrocardiogram or an ECG.
Right. So that's to clarify something you said there, right? I just want people to not be mistaken. What you described there is the very, very classical, they can't miss the diagnosis of a heart attack.
Correct.
Right? Which is not always the case.
Which is the majority of the time is not the case.
Exactly. So I want people to understand that, because somebody will be like, well, my chest pain not squashing down.
It's not really. No. I don't need to go to hospital.
No, and they could be very wrong. So in my clinic, right, my office, we have a rule that chest pain is anything from here to here.
Right. Yeah.
Anything from your belly button to your chin is a chest pain. And anybody who having pain in that area, we need to rule out a heart attack.
Correct.
Right? And that's the thinking that the person at home should have as well.
Right.
But I mean, if you're sitting at home and somebody clutches the chest, it's heavy pressing down, the pain in it, I mean, there's no doubt whatsoever.
You do.
And then you definitely give that person 4 aspirin.
Take them to hospital.
Take them to hospital one time. And diabetics could sometimes present very different as well.
They could just be having nauseous feeling, vomiting,
cold
sweating, and epigastric pain.
And shortness of breath.
Right? And blackout spells. Blackout spells and dizziness is the great mimicker in diabetics of actually a heart attack.
Right. Now, something that came in recently to us. What does someone do, another first responder, or even a doctor, so a patient has a low blood sugar?
Right.
So this patient is at home, they're cold sweating and all that. The family, I suppose, the first thing they should do is
check the sugar.
Especially if it's a known diabetic. You check the sugar, and the sugar is low.
Right.
What is low, and what should the family do?
Right. So many different associations, endocrinologists, and governing bodies of endocrine systems and diabetics define low sugar anything less than 70 milligrams per dl.
Right.
Anything less than 3.3 millimoles per day. So what actually happened is that it can go as low as 55 as well, some definitions say. But once it's less than 70, that is deemed as hypoglycemia or low sugar levels. The first thing is, a lot of these patients can present in a spectrum of symptoms. They can start off by cold sweating, feeling weak, feeling nervous, feeling anxious, or acutely disoriented, or having confusion, and it may seem that this patient is having a stroke. Right? But check their sugar. And if they can swallow, and if they can tolerate, give them something sweetened to drink. Right? One of the easiest sweetened drink is a Coke. You give them a sip of Coke, or you can mix some sugar water and you give them to drink.
Milk as well sometimes.
Glucose water or milk. And these things actually help to sustain the sugar levels.
To bring it back up. And then you carry them to hospital.
And you carry them to hospital, because it's not usual that somebody's sugars goes low, and if it goes low, we have to look at other causes.
Infections.
Infection. Is the insulin regime or the diabetic medication the patient is on is adequate? And a very important thing is to make sure that with the diabetes that the kidney function is good, because impaired kidney function does not clear your medications properly. So you have persistently longer medications in your blood.
That's a
and
really
then you can have a lower sugar.
In your blood.
Correct,
and I suppose people need to know what diabetic awareness, hypoglycemic awareness, so they'll know to prep themselves in the future.
Keep a sweetie in your pocket, as simple as that.
We have about 10 more minutes left. We have about 3 questions, right? So let's just get 1 or 2 of the questions in. Josh?
No problem.
If a person is not passing stool, how long should they wait before they go to the doctor?
Right, so constipation. Constipation is a common presentation in the emergency department as well. It is, because it is a distressing thing. It affects your activity of daily functions. So if you're worried about not passing stool, I advise you visit to the doctor, have a chat, let him examine you, because constipation can mean an array of symptoms, from something as an enlarged prostate to hemorrhoids, to the big C, or cancer,
Yeah.
right? Other diseases of the colon that may need evaluation.
Yeah.
So I would advise, yes, visit your general practitioner or visit an emergency department or a health center for constipation. Not necessarily you need to rush to the hospital or go to an emergency department. You can go to your health center, your GP, and they can give you some advice about it.
And I think you're right, and it's a very valid presentation to a GP office, a doctor's office. And it's not really that we want to hear that, oh, I've been constipated for 4 days or 5 days, and then I come to you. It's, listen, I am constipated right now. I've been constipated because there's a long list of things that the doctor wants to check to evaluate your general health as well. So you don't have to be you don't have to be constipated for X amount of time before you come and see us. It's a rolling assessment. But that's the thing about medicine. It's such a fluid game. Dynamic game, and it's dynamic while you're treating someone or while someone is suffering. It's not like you visit the doctor or you don't visit the doctor or you've gotten treated for that and that's the end of that. It's all about what happens in between, doesn't it? And we like to get feedback as well from people to know how they're doing.
Correct. And recurrent constipation in this particular situation could be a red flag of something dangerous that's going on inside.
And then the other thing about it is sometimes people might visit the accident emergency room, go home thinking that, well, I've already visited, that's the end of that. But then they begin to feel a little bit unwell. My advice to them would be to go back. Go back because that's the nature of medicine, isn't it? It's not stagnant.
And it always changes,
So, Doc, let's take the next question. Josh, please. How to treat a toddler showing allergy symptoms? I suppose allergy symptoms, let us assume that the allergy symptoms might be allergic reaction or
so we actually had a
allergy rhinitis.
We had a slide on allergies. So you can
put it up there, Josh.
Allergies and anaphylaxis.
Right, so this is allergic reaction, right? This is not sinusitis or allergic rhinitis. This is allergic reaction. Josh, you can put up that slide.
So allergic reactions is any sort of sensitive reaction to something that a patient is exposed to. And a sensitive reaction can simply be a response such as sneezing. It could be as a rash on your skin if something comes in contact. It could be vomiting, right? It could be a swollen throat, right? Those are all symptoms of allergies. Swelling around the eyes, swelling in the hands, swelling in the lips, right? So an allergen will trigger these hypersensitive response in your body. How is it treated? At home, you can give a little Piriton, Benadryl, right? According to the age, weight of a child or patient or adult, and bring the patient to the hospital as well in the emergency department, because we need to figure out and make sure that this allergic reaction is not progressing to an anaphylactic reaction, right? Because that is the important thing, because an anaphylactic reaction is an extreme allergic reaction where the symptoms are severe and life-threatening, and the treatment is very definitive and life-saving as well.
And cannot be delivered at home no matter what you do. This child has to go to the hospital. Unless they have
something called an EpiPen.
When they've been educated. Josh, you put up the next question, please. If you lose a limb, can it be reattached? What's the time frame? Let's talk beyond limb. What about a finger?
Right. So we could start as simple as a finger. So you usually try to get that piece of limb.
Good question.
A digit. Yes, that's a very good question. A digit. Get that into some ice, right? Or a cool bag of water, and you get that limb and the other part, you compress, stop the bleeding, and you take the patient to the hospital. Within a 2 to 4 hour frame is your time frame essentially. Right? And depending on the severity of the injury, a finger could actually be reattached. Parts of a finger could be reattached. A limb, if it's completely severed, the chances of reattachment and preservation of that limb is very poor. Because I've hardly ever seen
a limb being reattached. But you've seen digits?
Fingers, digits, parts of the fingers, sure. And it actually works, and it actually is revascularized, and it actually gets back. But it depends on the time. You need to get there
ASAP.
And you need to keep that piece of tissue in a little ice box, in a little styrofoam cup of ice. It usually always happens by
cold.
So if somebody liming or something, so you always have ice around if you're liming, and you put it in there and you get it to the hospital.
So Doc, we've come to the end of the program tonight. I want to thank you for coming in tonight. The purpose of this show tonight that we did is you're an experienced emergency room medicine man. You're doing further studies in it as well, hoping to extend your professionalism and expertise in the topic. But you're certainly given us some really valuable information tonight. I think the purpose was to allow people to know common things that happen in the community, what to do, and I suppose the take-home message is go to the hospital.
If you're in doubt, go to the hospital.
Go to the hospital. And these situations that you described will tell people as well danger. Help them recognize danger, because recognizing danger is a very important thing. Okay. Some people might not even recognize when something is dangerous. But these situations, they describe the dangerous situations that people need to get to the hospital. Yeah. And I thank you for that.
Yeah.
So guys, just thanks to Dr. Jonathan Sookbir again. We'll have him on again in the future. We had loads of other topics to discuss on emergency medicine that we thought of value, so we'll bring him on again in the future. And I'd just like to thank you at home for sending in your questions, and we'll see you again next week. So thank you very much, guys. This has been Your Health, Your Choice. I've been your host, Dr. Robert Roopnarine. We'll see you again next week. Take care now, guys. God bless.